Thanks for coming in today to our statewide session. Again, I just want to be kind of maybe a disclosure. This was not a public meeting, so all of you were either invited here or serve on our leadership team or on a committee or someone we are wanting to get more involved in Project Opioid. But this is a discussion of the importance of statewide collaboration. Now, don't break things. We just kind of just get it.
Just make a very, lively entrance.
I've arrived. So today we're going to be again talking about the importance of a statewide view of the opioid crisis in order to find local solutions. I think it's incredibly important for those of you that are involved in Project Opioid. Again, our goals, our Project Opioid is only 5 months old, but our goals are to align cross-sector leaders. I think we're seeing that happen in a very positive way. Increase awareness, create and share data. We have an announcement on some partners who are going to be working and fulfilling our need for the deepest dive into cross-sector and cross-institutional data on the opioid crisis we've ever done. That first wave of that data will start in about a week and be finished in October. And so data is going to be incredibly important. Coordinate between stakeholders, formulate high-impact strategies, and find solutions and save lives. So these were our original goals for this year. What's become very, very clear, this is what we knew. We knew that the scope of this crisis and the scale of the solutions needed were going to require everyone. This is not something that we could just, ask government on its own to try to work on. It was going to take folks from education, funders, criminal justice, the business community, healthcare, the faith community. We knew this, and we're seeing this happen in a way that makes me very proud, and our community, I think, excels at this. Hello, how are you? Skip by this and just say the area that I would say has become most clear that we're going to have to focus on that we hadn't necessarily talked about in the beginning, our leadership team hadn't talked about in the beginning, is the statewide partnerships that are going to be necessary to have a local, regional strategy and increased services help for those in need. It's simply not possible to expand your regional work on the opioid crisis without a crystal clear line to state partners on this work. Just a common sense explanation for that is using homelessness. Many of you have been involved in our regional work on homelessness. If you look at how funding and decisions are made on homelessness around America, not just in the state of Florida, much of the funding is allocated to communities through local vehicles that really have national origins. The Housing Authority, that's national, that's money in the federal budget that then has pretty much the discretion of a local housing authority here in Central Florida. There are 6 housing authorities, Nancy, in Broward County that don't need anyone's help other than their boards to make decisions for Broward County on how they spend that money. The Veterans Administration has on homelessness the greatest amount of money, really, if you look at the national pie to solve that issue. A local VA has, you can fire the CEO if he's not doing a good job, but that local VA has almost exclusive discretion on how they implement programs. That is not how we believe the opioid crisis works for hospitals, for law enforcement, for behavioral health providers, for those that want to see prolific medically assisted treatment available. These are statewide resources that flow much of the time through statewide partners and ultimately are going to require for a local solution statewide connection. Does that make sense? So we're here today to talk a little bit about that, hear from some key partners who will shed light on their purview of what this means to our community, and talk a little bit about, between now and the end of the year, what this will look like. A couple news and notes, because I don't want to forget to tell you this. Mark your calendar. We haven't made this public yet. We'll make it public on July the 8th, so don't tell anyone in the media, okay, that the publisher of the Sentinel sitting in the front row. So and the vice president of CBS Local 6 is right there, so don't tell anyone in the media. But Project Opioid is going to be hosting Governor Ron DeSantis and the First Lady Casey DeSantis in the morning of August 20th for a huge business and faith leader event that really will serve as kind of the public kickoff of Project Opioid. We believe we'll have hundreds of business leaders, hundreds of faith leaders right across the street at David Swanson's First Presbyterian Church. And I'll tell you, just a lot of you serve on the leadership team at Project Opioid. We want this meeting to feel different. We're hosting it in a church for a reason. One of the most important parts of making progress locally on this opioid crisis, we need to humanize this crisis. The amount of people, Representative Nick Duran, who's going to be speaking in a few minutes, representative from South Florida, you'll be hearing from him, but we had, a few of us had dinner at Red Lobster, about 8 of us, as the guest of the CEO of Red Lobster, which is kind of everyone's like, that was such a cool thing, you know? He's taking us through the menu, and he created the menu. So
a lot of other talented people.
Yeah, always humble.
I just want your biscuits.
It's true. Cheese biscuits. It's the cheese biscuits that they get them every time.
It really is.
But Representative Duran, you know, he is someone you'll hear about. A young guy. We served in. We're together in Leadership, Florida, but he was talking about his work on the opioid crisis, a lot of other projects that he works on around the state. But when he talked about why he was involved in the opioid crisis, he talked about his brother-in-law who lost his life to this crisis just a couple of years ago, and just. We're having this policy conversation. We're having this conversation about this issue. And then suddenly it's not that. And then suddenly it's about a family. It's about a mother and a child who now have to go through life, without the patriarch or their family. And the way he described it, and I'm sure he'll tell you more about this later, but this man was in recovery. And he was doing so well, and then in a period of 1 month, he went from success ultimately to losing his life. And so, we must humanize this crisis if we are going to have success, both in Tallahassee and here in Central Florida, to get more resources and to get more, to break the stigma around this addiction crisis, to get more help for those in need. So mark your calendars, August 20th. Governor DeSantis will be here, and we think that's going to be a great event. One other thing I'll just tell you, news and notes wise, we are, the timeline for Project Opioid, especially with a statewide lens in mind, is that we are pulling together again. We're going to be working with our hospitals. DCF is going to be a great partner with data, our behavioral health partners and others, Florida Blue and others, to look at the data on the opioid crisis, pull that together, and then in October, late October, we're going to be partnering with the Orlando Sentinel on their editorial board contacted us about 2 weeks ago. They gave us an early warning about the Never Trump editorial that they put in. I'm just kidding, they didn't do that. Just Nancy's like, you have to bring that up, Andre. It was one of the best parts of our dinner conversation last night. So, but the Orlando Sentinel and their editorial team is going to be doing what they don't do a lot. They're going to be doing a public event where they help us get the word out about the opioid crisis and Project Opioid. and we will be releasing that data at the event. So, so that's exciting. All of that then leading up to what is possibly a real opportunity to make changes at the end of the year on the statewide level that then can trickle down to our community. So let me actually just take 1 second, no speeches, please, but take a second and just introduce yourself, tell us who you are, and then again, just really brief, because we'll get through everyone, and then we're going to get right into the presentations.
That's what I get for being late. Julie Griffin, Darden Restaurants.
I'm Anna Lowe, the Chief Operating Officer with Central Florida Cares Health System. We're the behavioral health managing entity here in this area.
Nancy Meyer, publisher of the Orlando Sentinel and Sun Sentinel in Fort Lauderdale.
Good morning, Ute Gazoich, and I'm the Director of Substance Abuse and Mental Health for the Department of Children and Families.
Kim Walker, CEO over at Long Street.
Aaron Wohl, I'm an emergency physician with Lee Health in Fort Myers and associated with the Florida College of Emergency Physicians.
Beth Brunner, Executive Director of the Florida College of Emergency Physicians.
Nick Duran, State Representative.
I'm Sharon Washington. I'm with the Florida Department of Children and Families. I'm the Regional Managing Director for the Central Region.
Good morning. I'm Scott George with Feeding Children Everywhere and Pine Castle United Methodist Church.
Carol Burkett, Deputy Chief of Staff for Mayor Peter Hills. I'm Heather Sherman. I'm the Director of Health and Welfare for Window Destinations.
I'm Erin Palmer. I'm Corporate Communications for Window Destinations.
I'm Brian Gray. I'm a VP of Organizational Capability for Window Destinations.
David Eminato, News 6. Chuck Steinkamp, Regional Director for Alcatraz.
Kathy Russell, Special Assistant to Mayor Buddy Dyer.
Paul Cortez, former state rep, now representing the Orange County Sheriff's Office.
Joel Hunter, local faith leader.
Sonia Pfleiderer, Service Provider with Central Care Mission Building.
Spence Platter, CEO of Central Care Mission.
Brooke Rennie, I'm a nonprofit and political consultant.
Kat Checo with Florida Blue.
Hi, I'm Brad Rex. I'm the CEO of eHome Counseling Group.
I'm Derek Stevens. I'm CEO of Phoenix Healthcare Consultant and Florida State University Fund.
Scott Spielman, I'm System Director of Behavioral Health for Advent Health.
This is Hannah and Matt from our team. Wave at everyone. All right, so with no further ado, Representative Nick Duran, come on up here. District 112. I was trying to figure out where is District 112. It's now. So does it look like, you know, a banana, or is it like?
Mine is fairly box-like. Not sure how familiar you are with. Good morning, everybody.
Welcome in.
So District 112. So my district is down in Miami. Everything south of, if you've been to Miami, south of Cayo Ocho, you have Brickell, you have Coconut Grove, Coral Gables, Village of Key Biscayne. It sort of encompasses my district. That said, I have a lot of the work that I've done in the professional level. For many years, I was a lawyer, and I decided to move into the nonprofit world. That's about close to 10 years ago, 2010, that I decided to work with a gentleman named Dave Lawrence, former publisher of the Miami Herald, who's a big advocate on children's health care and children's early childhood investment in early childhood education. And so it forced me to do a lot of state work and across the state. Right now, I'm the executive director for a state association called the Florida Association of Free and Charitable Clinics. We represent free and charitable clinics across the state of Florida that provide free medical services to the uninsured and working poor in our state. Here in this community, you have some of the most stellar ones in the nation. If you know about Grace Medical Home, or you've heard of Grace Medical Home, is actually one of the most premier clinics in the state. Shepherd's Hope is another example. Those are members. Those are the kind of clinics that we, as an association, that we represent across the state. So I have the opportunity to do a lot more state work and state perspective type work. I'm here to talk about opioids, and I think the best way to start it is kind of thinking about, to quote my old boss used to say, is seek outrage daily, but don't be bitter. And I think in that is when you find yourself in bitter and stuck in bitterness, you aren't actually able to actually act and work on issues. So find those issues, be outraged by them, motivate yourself to move on those sorts of things. I'll sort of say that I was elected back in 2016, and I had declared, kind of give you a recap on my history and how opioids and this issue, substance use and opioid use disorder, kind of came into my life. So in April 2016, I decided, and a lot of this discussion and decision making, we decided to go forth and run for office in my district. This is a district that my family came 54 years ago from Colombia and made bought their first home, and that's the district where I get to represent, in the place where we started our American story. And I would say, and fast forward to a month into it, we're rocking and rolling. My father-in-law, my entire family were moving along the lines. And my brother-in-law, David, who we were just talking about, he was 7 years clean, and he had issues with substance use disorder, but he fought hard, and we sent him to all sorts of different treatment facilities outside the state of Florida and California, and Costa Rica, all these different places. And he came back, and he built a life. And he was, fairly successful, doing really well. He had a wife. He had a child, a young baby that we were around that time. He was about to be 3 years old, and was building a good life and really learning to sort of thrive and live with what was his disease that he was dealing with. And within a month, we started seeing a lot of erratic behavior out of him. And next thing you know, him and his wife are having all sorts of divided discussions, and we're sort of seeing that there's a separation involved, and his business is starting to go down. And we realized quickly that there was an issue, and it was almost 2 weeks before we sat him down and we said, look, we know that there's some things going on, and he admitted to us that he had issues, and he was careening down a path that we knew was dangerous. And we even said it to him, we're like, look, I think we're, and it's cold hard truth to feel that way and say it to somebody, but we think you're gonna die if you don't take some action. And he ends up dying a month into the campaign. And it was fentanyl intoxicity is what they called it. And we know that's opioids, and that's a part of opioids, and it was a part of the big issue that was going on. But that weekend that he died was the weekend that we were supposed to be celebrating his son's birthday. So one of those kind of life sort of issues. So in that darkness, we saw outrage. We were outraged by it. And I think a lot of what I was running for and what I felt like I needed to run for, it kind of changed my direction on some of the course of action of what I wanted to look into. And so one of those days, late in the night, I'm sitting with my wife and looking at the PDMP, the prescription drug the prescription drug program that we have, the system that we have in place so that doctors can look into it and see how many of their patients are prescribed opioids and other substances, and you realize the sheer volume of opioids that have been prescribed in the state of Florida. The system itself was outdated. It was very controversial when it came to the state of Florida. 2009 is when we actually passed a law to have the prescription monitoring program in place. And we didn't actually invest in it as a state. We had to use grant dollars. It was like part of the first iteration is we cannot use state dollars. It has to be grant dollars to fund and fuel it. And then when you actually went to the system, you realize, wow, why would any doctor want even to play in the system? It's terrible to get to log in, to pull out the information. And so I realized quickly, one, we have an enormous amount of prescription drugs that we are putting out in the state. The reporting requirements in it, you can take 7 business days to look at it. You can send in the information via a CD-ROM. So there's a lot of issues with our own sort of investment and our own sort of emphasis on this program and this tool that in many respects should be able to facilitate the doctor's real-time assessment of a patient, saying whether or not it makes sense for them to prescribe opioids, and or if they have a patient who's careening towards addiction, how can we intervene? What can we do to intervene? And I think I saw something that I think was important. So my first bill that I passed when I was in the legislature was to modernize our prescription drug monitoring program. The representative was a huge supporter, and he was there with me to help say yes when we pushed that button. And it was an important sort of victory, I think. It was a small step in what I think is a massive problem and a massive issue and what we need to do. And I say that because when I came into office in 2017 was my first session, we started making some very monumental moves as a legislature in how we took on the issue. First, we started actually investing into our prescription monitoring program, state dollars, and that allowed us to invest in the modernization and really build out a system what we can say the doctors want to go into, can go into if they need to pull this kind of information. We realized, and we started to have this discussion on, should we mandate whether a physician should be limited toward the amount that they can prescribe of opioids? And we didn't pass it that session. We had a big debate We ultimately said yes, but we ended up holding back on that. And then the following session, we passed a big bill that did just that. It was not perfect. There are a lot of flaws in it and how we defined and what we said within there. But we did say that we had to make some bold moves. And really the medical professionals that were now limited to a 3-day initial prescription of opioids is to 3 days. We had to make those sorts of hard decisions to move in towards that sort of place. And it was a bipartisan, and I think in many respects with this particular issue, it has been a nonpartisan issue across the board. And so, we started to sort of nip away at those sorts of things with respect to actual prescribed opioids, right? Well, I'm going to talk about that sort of side for a little bit, and then we're going to talk about what I think is the next massive hump in that sense. So if you look at numbers now and you were to look at what we see, we are seeing a reduction. I think it was saw a 17% reduction in Florida particularly in the number of prescribed opioids that are out there. And a lot of it has to do with these regulations that we've put into place. There's new CME, continuing medical education requirements for doctors. We actually just passed something this session for dentists with respect to those educating on how to prescribe, properly prescribe, I guess, and safely prescribe opioids or thinking about those. We started creating and facilitating alternatives to non-opioid pain treatments is another place that we've been starting having a lot of conversation as well. And then we also invested a lot of state dollars into other places like Naxalone, thank you, and which is really just kind of help save somebody as opposed to sort of treat them in that sense. So what you've seen an emphasis in is on how do we slow down the prescribed opioid stream. And how do we save people's lives, and how do we reduce the number of people's deaths? Because I think I look at David's death and I look at him and I look at that. That's just an example of what we see at the greater picture, right? This is a human being at a full potential who just, no longer there and no longer able to move forward, and now has a son who has to sort of deal with an issue of not having his father. And I think that we sort of look at it, we've got to maintain that human perspective to what we're dealing with here. So we have slowed those down. We are starting to slow down the number of deaths, I would sort of say, because of that, because of the injection of naloxone into our program, the amount of money that we've invested. And so I think one of the biggest issues now that I think we're starting to move towards is the second half of this, which is we can save their life. We can slow down the amount that's out there in the stream. But what do we do with them afterwards? How do we get somebody like that? One of the things that I truly sort of realized with addiction is that it's a lifelong sort of battle. This is not something that you're going to sort of get rid of in 30 days and walk on and maintain your life and continue on. This is a never-ending, lifelong, long-term battle that you have. And I think one of the most profound statements that I heard was from our former Surgeon General, when he was beginning to sort of say, we need to look at substance use, opioid use disorder, as not a mental, as a moral failing. It is not a moral failing. It is it's a disease. It is something that you have to look at akin to as cancer and other diseases that we fight, that we have to deal with, that we have to manage and work on dealing with. And I think that one of the biggest issues is really that sort of long-standing stigma that it's a moral failing. And it kind of leads me to the second hump, which I think is critical for us. And when we kind of look at what are the ways that we can deal with providing more access to treatment. And I think that the first fundamental step that we need to have is kind of really all kind of come to a point where we say, this isn't a moral failing, this is a disease. How do we take on and cure a disease? How do we help manage a chronic illness in that same sort of way and realm? And that's sort of been my fascination, what are we doing? And the reality of it is all of this costs money. And how do we pay for it is always going to be a part of what we're dealing with here. So one of the things that I wanted to kind of talk a little bit about are some of the ideas that we've seen other states doing with respect to the access to treatment issue that we have in place. And I think it's also important to note, and I was looking this morning before I was preparing for this, at some of the issues that we currently have with respect to access. And I think that what we saw here is there's 2.1 million people. This is a new report that just came out in June. who have reported using heroin or abusing painkillers in 2017, and only 680,000 sought treatment at reporting treatment facilities. So that's about 32% receiving treatment. That is 70+%, just a little under 70% that are not. And one of the main drivers that they say is for not receiving treatment is that they didn't have health insurance, their insurance didn't cover addiction treatment, or their cost sharing was unaffordable even if they had coverage. So affordability towards coverage is a big issue that we're sort of dealing with. Now, how we deal with it and how we fund it is a couple of ways. One, we do have, the state is suing Big Pharma, and we will see what happens there. There's a lot of states doing it, and I do believe we'll see some sort of funding that will come out of that. And rightfully so, in many respects, we have to deal with what is the consequences of a self-made. This was driven by a few bad actors in a sense that helped kind of create this issue. So will we have some funding there to help take on the cost? Yeah, but we were talking about billions of dollars the state of Florida has already sort of seen in costs with respect to increased healthcare costs. What we have to do, we were talking a little bit earlier this morning about our increase in investment and how the healthcare part of the budget continues to increase and how we have to sort of deal with it. And a lot of it has to, I would sort of say to you, is the necessity to take on this issue with opioids. We have had to really inject a lot more money than I think we expected in order to deal with adding more naloxone into the system, into dealing with the increased emergency room healthcare costs from folks showing up there and just being saved, et cetera. And so the second step, and I think we were talking yesterday about what is it that we can do and what can we do to make sure there's more access. So we know that there are a bunch of different routes to solving this issue. One is residential treatment centers, medicated assisted treatment programs in place, and a lot of these programs are covered by Medicaid in some places. Most of Medicaid covers all the Medicaid assisted treatment programs, but our Medicaid program is very tight and regimented. The amount of people who are actually eligible in the state of Florida is very limited in our state. If you're an adult without children, you're basically not going to be eligible to be in the Medicaid program. We also know, and really, depending on who you are and where you're from, how you lean politically, the discussion on Medicaid, expansion of the Medicaid program, we say that wholesale and how it looks like and what it looks like there. But there's a lot of states who have looked at the Medicaid program, that the way that it's been provided, the state, the administration, the Trump administration has actually sent down guidance on, hey, if you wanted to revise and tweak your Medicaid program, expand out the population with respect to opioid use disorder, there are flexibility opportunities, and other states have begun to move towards that. So if we want to create if we want to propose this, it's called the 1115 waiver. It allows our state to propose to the federal government, we're going to expand the Medicaid in this limited population, and a few states have done this, for folks who are suffering from an opioid use disorder or substance use disorder, so that they can receive, they'll be in the Medicaid program for this limited particular issue that they have to deal with. And there are states who are walking down that path. So if we don't have to talk about Medicaid expansion on a wholesale level, but we can talk about it on a very sort of surgical approach to how we deal with substance use, and I think that it's a part of how we pay for the program. We are paying for it anyways. And one of the things that I found so intriguing about, I serve on healthcare appropriations, the ranking member in healthcare appropriations, we're the ones who build up the healthcare budget. One of the things I found so fascinating over the last 2 years is how we fund treatment in the state of Florida. And a lot of it is through like member projects. We each come in with a single project that somebody has brought to us, and they say, hey, I would like to fund 10 beds at this particular center, and I'm looking for $500,000 for this. There are dozens and dozens of those kinds of projects from members across the state. And so it's kind of like a piecemeal system that we've currently kind of approached the treatment centers and treatment access to treatment in the state of Florida. I think when looking at a Medicaid Medicaid expansion on very surgical level. It can kind of eradicate those Medicaid, those kind of single member projects. We really have to look at that. I think the other piece, and I'll just add it to this, when I said to you that it's not a moral failing, it is a disease. You think about Medicaid assisted treatment, MAT, what we'll call it, and there's someone who knows it better than myself right here as an advocate, and I'm sure he'll talk to you all about it. But it's, if you think about it and we move towards that sort of paradigm of thinking, what we can do is sort of realize that yes, Medicaid assisted treatment is like sort of giving somebody some drugs in order for them to sort of wean off the drugs in a sense. But it's a part of the solution. We're not facilitating someone's continued drug use. We're facilitating their exit out of that sickness. And so I think there are opportunities for us to look at Medicaid as a vehicle. We've seen it in other states. There are a lot of opportunities there. There are also ways that we can revolutionize, and I think there's some other places. They're called in-home substance use treatments that are now we're sort of seeing, instead of sort of think about like this, we thought about nursing home care and then in-house care. We sort of wanted to move away from everyone staying in the nursing home, and we thought maybe we can, if we can keep people at their homes, it could be a much more effective way of helping continue their living. And there's a lot of that happening in a few other states. Connecticut has kind of been a driver with this, in saying we can create substance use programs and treatment programs in the home sort of situation. I think you're sort of seeing that concept being studied a lot more. And the Florida Blue actually up in that area has brought it in as one of their coverage items in their sense. And then I think also the reality of it is this: we as a state, if we believe that these sorts of coverages that our health coverage, our health plans are not covering them, we have to have a lot more discussion on that, because there are some dollars and cents sort of ways that we can position this, that it is far better investment in the front end with these particular types of coverage items. When we talk about alternatives to non-opioid alternatives to pain relief and pain coverage, these are the kinds of things we have to deal with. And then finally, we had the great conversation about this. The culture of pain is something that as Americans and as Floridians, we all believe that we should be able to solve it so there's zero pain in our life, that we can walk without that. I think that's not the reality. And so how do we break that culture, I think, is a part of how do we look at substance use disorder? How do we begin to talk about pain relief and those sorts of situations? As a state, I say to you, we will continue. We're still going to fund these programs until, and I expect to see another 50, 60 member projects on residential treatment center beds, because they're real. That's really happening, and we know that there's a real need for that. But again, and this is to sort of say, we talk about not expanding the Medicaid program. Yet we still put these projects in, and the reason we don't expand Medicaid is because it's an entitlement program that we don't need. That these folks should be able to do it on their own. They should be able to get work and handle those sorts of situations. Yet at the same time, we're filing these projects on a single level. That is basically what we're already saying is the same thing. We're doing that entitlement program in a very different way. I think with an expansion of the Medicaid program, specific in this one, it allows us to sort of create the accountability measures that we need. It allows us to create and leverage the dollars that we need to bring down on a federal level that we aren't bringing down, but we're paying for at our own level in the state of Florida. So there are creative models. There are creative models outside of the Medicaid program. There's creative models within it. And I think that all of those are on the table. And really what it really means to you is I think that we have gone up the hump in terms of slowing down the amount of opioids that are out there with prescription opioids. But now we need to deal with the reality here that is how do we treat substance use disorder? And that's a life, like I said to you, a lifelong expensive ordeal. But if we don't fix it or we don't find those solutions, it continues to be a suck on our federal and our state budgets. Happy to talk or answer questions, but I think I'm going to respect the time frame that they've given me.
Give him a round of applause. We're going to be working with Representative Duran a lot over the next few months. A few things just to kind of think about really quickly. Sometimes this doesn't make sense unless you think about it through the lens of if Sally is right downstairs and she is addicted to opioids. She now somehow has traveled to being addicted to heroin, which so many of these folks make that transition when opioids aren't available to them. What's available to Sally? What help could she get in order to stabilize her life, break that cycle of addiction that often, because of fentanyl, is leading to death? And so when you hear him talk about these waivers and all of these, resources and a partial Medicaid expansion, think about it through the lens of right now, I think, and we are going to show this, you just wait till October. We're going to show this with data in a way that's absolute in this community. The truth, and there is no other truth, is that if you are addicted to opioids, which is putting your life at risk, there are very few options for you. Anyone who tells you something different is not being honest. So, what was the outrage? So, and the fact that that is outrageous is what is outrageous. So, but in order to solve that, we're going to have to look at resources being made available and then bringing those resources to bear in communities in intelligent ways. By the way, the 1115 waiver that he's talking about, which is the workaround, which I don't really understand this that well, working around to not expand Medicaid as a whole, but working around into the same pot of money for an issue, sounds impossible. Well, we already did it on homelessness. So when we expanded the supportive services for those who were in permanent supportive housing, then Senate President Andy Gardner helped us draft legislation that we didn't even know what it was. And he was like, we're just going to do this waiver. We'll just go around to ACA and pull the money. Okay, Andy, you do that. But we wound up doing it, funding some of the first pilot projects of supportive services for those who were in supportive housing. Again, the point is, it was a Medicaid expansion that got through because it was specific in nature. What if we could do that on this opioid crisis? That's something we should really look at. All right. I now want to introduce Ute Gazoich. Gazoich. You would have all messed it up too. Don't judge me. Come on up, Ute. Ute is the Director of Substance Abuse and Mental Health. I'm going to hand you this clicker.
All right, great, thank you.
And I will tell you, I had a chance to visit with Ute and some of her leaders. Had a chance to say hello to the new Secretary of DCF, Chad Popple. This is an issue. Secretary Popple's been on the job a couple months. This is a former business leader, a guy worked with IBM. I believe the governor has tapped him and asked him to look for creative solutions to the opioid crisis, started a new Department of Innovation statewide at DCF. So I brought Ute in and said, Ute, as the Director of Substance Abuse and Mental Health for the Department of Children and Families, what is it going to take for this state and this community to really get help for those in need? So give her a round of applause.
Thank you. Good morning. And I'm so excited to be here. Thank you so much for having me, because this is not a government problem. This is a community problem, and it's going to take a whole lot of partnerships to get to some good solutions. So I'm going to caveat this by saying that when Andre and I talked about this, he said, do the magic wand. So I'm going to, because I'm not shy about those things. So I'm happy to have some discussion on that, because some of it may...
Just to clarify, this is what I told her. I think this is important.
Yeah. This is
what really, like for real, changes need to be made to get help for those in need, both here and around the state, because you really can't do one without the other. And if you had a magic wand, what would you change so Sally and Bill and Tim and all those who are addicted to these drugs could really get help?
Right.
So she's telling us what really needs to change from her perspective.
Correct. So just to give you a very brief overview, and I'm not going to go through these bullet points in detail, but a lot of people don't even know that the Office of Substance Abuse and Mental Health is housed within the Department of Children and Families, because we also do child welfare and Medicaid eligibility, so that usually takes preference. But We are actually the single state authority for mental health, substance use disorders. We are also the methadone authority of the state. And with that, we establish rules. We manage all the federal funds that are coming in, those huge grants that you hear about, the state opioid response grants and several other grants that we manage, as well as the state general revenue. Our major population is individuals who are either indigent and can't afford care, who are uninsured or underinsured. And I'm very happy to hear Representative Duran talk about the underinsured, because we have loads of individuals who have insurance, whether that be Medicaid or private insurance, and they're still showing up in our system, in the safety net system, because there are so many services that are not provided, that are provided under state funding, and by the fact that the insurance companies don't cover it, it makes those individuals eligible for it. It's on a sliding fee scale, but still. And it's important to say that because, you know, state dollars, state tax dollars are paying for those medical services, even for individuals who have insurance. We have a privatized system. Our dollars flow through local, what we call managing entities. And as Anna said, she's the COO of the managing entity here in Central Florida. And basically their job is to plan and coordinate their system of care. The purpose was to get those planning activities around behavioral health services at the local level to improve access to care, promote that service continuity, and for those managing entities to have strong partnerships with their local partners, as well as the managed care plans in that area in order to leverage resources and build comprehensive systems of care. Just to give you an idea, again, Central Florida Cares has 4 counties, including Orange County. To give you an idea of what our funding is in the substance abuse field in terms of just federal grants that we get a block grant that's a little over $100 million every year. That's regular funding. It funds all substance use disorder treatment, including opioid use disorders. We have a Partnership for Success grant, which is a prevention grant. We want to get upstream. We want to invest in prevention. So that grant funds our overdose prevention training, as well as school-based prevention programs. And then we just ended the state targeted response to the opioid crisis grant, which was $27 million, and then that moved into the state opioid response grant. That was a $50 million appropriation for the state of Florida. But what happened is Congress approved the funding for the state targeted response grant, but not the grant program. So they've moved the funding into the SOAR grant. So that $50 million actually turned into $76 million. And that is specifically dedicated to all things opioid, and I'll talk a little bit about what those dollars are doing. So when we wrote that initial grant for the targeted response, these were our goals. Number one, reduce opioid deaths, because although our biggest mission is treatment and recovery services, we can't treat anybody who is deceased. So we started our overdose prevention program back in 2016. And actually Orange County is probably one of our best customers, so to speak. They're really ahead in terms of naloxone distribution. Because Orange County is one of the few counties in Florida where your fire department has a leave behind program, which means that anytime they respond to an overdose, they actually leave naloxone kits behind. Advent Health is a partner where we supply naloxone so that they can supply naloxone to individuals leaving the ER. So you guys are ahead of the game. Again, our approach is school-based prevention, to get upstream, broad naloxone distribution. I want to make it really clear that our goal is community distribution. It is not just for first responders or hospitals. Those are folks that should have that on their truck. It is hugely important to get naloxone kits into the hands of community members, people who are at risk of an overdose, and loved ones whose family members or friends whose family members are at risk. 50% of overdoses have no call for help. because people are usually using together and they are scared to be arrested. And although we have Good Samaritan laws, our Good Samaritan law still allows a person to be arrested. It keeps them from being prosecuted, but they can still be arrested. So it's not conducive for anybody calling for help when somebody's overdosing. So it's hugely important that we get naloxone into the community's hand. Medication-assisted treatment. I will say this, and there's a lot of treatment providers who will disagree with me, but we have done extensive research, and the gold standard for opioid use disorder is medication-assisted treatment. If we continue to put folks into residential treatment and detox without the associated medication-assisted treatment, you're really setting people up to die. Because what happens is you lower their tolerance for their opioids. There's almost 100% chance that there's a relapse. They go and they use at the exact same amount that they used before they lowered their tolerance, and they die. So these are not indicated treatments in the absence of medication-assisted treatment. Hospital bridge programs is another one of our priorities. It's been slow going. It's one of the things Dr. Wool and I get very frustrated over, and basically we're trying to pay for specifically peer specialists who are much better at engaging individuals than most other folks to actually be housed in emergency rooms. So when you have that window of opportunity to engage a person into treatment, to actually have them talk to them, engage them, if they're not ready for treatment, then follow them for a few weeks. Basically, we call that therapeutic stalking, but that's okay. And hopefully get them into some kind of treatment. And we really need to talk about recovery opportunities. This is not just a treatment issue. As the representative said, we can't just go to put somebody into treatment for 30 days and think this is over. Substance use disorders are chronic illnesses. They're like diabetes, they're like heart conditions. They're not something that just go away, and we need to start looking at them as medical illnesses. I know there's a lot of judgment, but I always liken it to if a person has diabetes and they don't stick to their diet and they eat terrible foods, do we cut them off? Does their endocrinologist say, well, you keep gaining weight, you keep eating chocolate, I'm not treating you anymore? We do that in our industry, and that's something that really, really needs to change. We all need to start looking at this as a chronic illness. But beyond the treatment part, we really need to start investing in recovery opportunities. And this is one of the most cost-effective things we can do through recovery residences who, like the Oxford House model, pays for itself because they're a nonprofit, they set up homes, and within a month, the residents are expected to have a job, they pay their own rent. So it's a recovery community that costs us absolutely nothing. Recovery organizations where people can go when they're having issues, when they've been in recovery and they're having a hard time, to talk to people who've been through the same thing they have. And then we've really concentrated on training health professionals, behavioral health professionals, and so forth. So we've made progress, and I'm not going to go through everything, but the timeline is kind of interesting. So you've had prescribing go up in prescription opioids, and you've had this rise in death. In 2012 is when our Attorney General at that time pretty much shut down the pill mills, and so then you had this slight decrease, and then what happened is all of a sudden you had these huge increases because we cut off people's opioid supplies, so they went to illicit drugs. This is kind of like your spike to heroin. And once the heroin became popular, between 15 and 16 is when the fentanyl came in. And that's where you had that 55% spike. Good news is, although it was an increase, you went from a 55 to a less than double digits increase. And the CDC is anticipating, not definite yet, but is anticipating that the 2018 numbers may actually be lower than 2017. So I won't go through this because it's just outputs. We have increased in our network, the safety net network. We've tripled our capacity to buprenorphine providers. Also had a huge increase in Vivitrol providers. Those are some of the FDA-approved medications for opioid use disorder. What we do see is when we keep people in treatment, we're seeing 94% drop in non-fatal overdoses for people who stay in treatment at least 180 days. Stable housing goes to 95%. Employment goes from 21 to 53% in 180 days. And we've had at this point, well over 3,000 self-reported overdose reversals. So when we keep people in treatment, we do well. What we don't do well is keep people in treatment. So well over 50% of persons who started in these grant-funded MAT programs, were either discharged administratively or they dropped out of the programs. So we'll talk a little bit about that. So here's my magic wand. What are the
Discharged
things?
administratively mean kicked out of the program for non-compliance, or it means they were a success and they're no longer needed treatment?
Kicked out for non-compliance. Yeah.
Which is a stigmatization in and of itself.
Yeah.
Right.
In other words, the providers who are trying to diminish stigma among other providers are stigmatizing the patient because they're relapsing.
Yep.
And I
Or
think
they're, quote, the word is, they're testing dirty in their urine. Even that utilization of that term is a
Yep.
stigmatization of this person with a disease process.
Yep.
They're popping positive for illicit substances, but it's part of their disease process, and
Right.
yet we're kicking them out.
Right.
So I think that's a huge shift that this crisis is bringing on. Is how do we provide services? So we have a lot of opportunities for improvement. Number one, increase our prevention, get upstream. Using evidence-based prevention, okay? There's a lot of people, very well-intentioned people, who want to do prevention activities, big meetings, but they have no outcomes. Kind of like the DARE program that actually was completely ineffective, and DARE schools had higher substance use rates. It's really not about say no to drugs. That just doesn't work. We know that. It's really about teaching kids life skills, teaching kids how to be resilient, how to make good decisions. And that's what is actually the protective factor and the good news is the evidence-based prevention is working because our substance use rates among youth has been on a constant decline over the last 10 years. The only thing that we don't see a lot of movement in is alcohol. And marijuana, although there was a slight decrease in the last couple of years. This is the number one thing in terms of if we want to prevent death. It is the easiest thing to do. You don't have to have a degree. Naloxone distribution. And not just to first responders, but the community. So in my dream world, naloxone would be there would be leave home kids from every EMT. There would be take-home kids in every emergency room. And that we don't do that is a little bit surprising to me because we'll talk about those statistics.
Now that we have our representative here, Statute 381-887 will need to be amended for that particular issue right now. In Seminole County right now, law enforcement is allowed to carry naloxone, but our civilian employees are not. And under statute, that needs to be corrected because in addition to the statute, it provides the civil immunity from giving the naloxone. So it's important that, yes, I agree with you, everybody should be able to do it, but there's going to be needing a legislative change.
You can also, if you have any kind of, whether it's from your fire department, if you get a standing order from a physician, you're actually covered. So it's, and for anybody, we have sample standing orders that we're happy to send to anybody. So that's the number one thing. Secondly, we have to increase access to medication-assisted treatment. We talked about Medicaid, insurance, addressing the stigma. This is a chronic illness. Also the stigma of medication-assisted treatment. You'll still have people say it's replacing one drug with another. Yes, methadone is an agonist. It is an opioid. Buprenorphine, partial, sometimes it's mixed with naloxone, sometimes not. Vivitrol has absolutely no opioids in it. So the problem with that is people have to detox first, which is kind of a scary proposition, and then go on Vivitrol. But these are FDA-approved medications, and I can tell you that methadone is probably the most studied medication in the history of man, unless you know of one. Yeah. And the retention rates speak for themselves. Is there a risk of diversion? Absolutely. There's also when a psychiatrist or a primary prescribes Ativan or any kind of benzodiazepine for Anxiety, those are sold on the street as well. Whenever you have something that makes somebody feel good, you're gonna have a risk of diversion. And so we really need to look at it from a harm reduction perspective to say, what are the harms versus, what does well. The other thing is, again, improve that engagement and retention and remove some of the arbitrary barriers that we put out there. Program rules. We still have programs who say you can only get the medication if you agree to come to therapy every week and then come to a group. Well, if I don't want to do that, then I don't get medication. To me, that's irresponsible. It should be a medication-first model where we're going to save your life, we're going to give you the medication you need, and then if we're good at our job as behavioral health professionals, we should be able to engage people over time at their pace, because that's what Social Work 101 tells you. You start where your patient is at. You don't force them into things. If I were to go to you right now and say the only way you're going to get your diabetes medication is if you go see your dietitian every week, and you don't go and you don't get your medication, that doesn't seem
That's
reasonable.
exactly what's happening.
And it is happening.
That's exactly what's happening. If the patient wants to be on medication and they only want just medication and they're not interested in behavioral health counseling, they remove the medication because they're not going to go to counseling.
And people will tell you none of this works without therapy.
Not
and this
true.
has been well studied, and it's not true. It's not true. I'm not saying people can't benefit from therapy. I'm in this field. I've seen therapy do amazing work, but therapy works when a person's ready to do it. So you have to get them there.
And it's also the National Institute of Health and
Yes.
Sciences just put out a report that said you should not preclude giving the patient medication if behavioral therapy is not available.
And to a point made earlier in terms of access, how many people go, it's not just that things aren't available. People don't seek treatment. Low number of people seek treatment. We have to get better at outreaching to people. That includes street outreach, which people are shy to do, but it's very effective. It includes these hospital bridge programs so we can get people at a point in time, and also needle exchanges. And I know that there's a lot of controversy on needle exchanges, but I can tell you that all the research shows that it does not increase use. Cities that have them have lower rates of HIV infection, Hep C infection. So even if people don't get into treatment, it still lowers their chances of getting diseases that are transmitted. And it's a harm reduction public health model. It's also a great place to engage people who normally would probably never come to treatment doors. And if you can engage and build trust, you may be able to get those folks into treatment. Again, on the insurance side, we're still seeing people denied for services because they have a positive urine. We've seen that on MMA plans, on private plans. Our providers do it. Insurance pre-authorizations are a huge barrier. Substance use is really unique. You have like maybe a day when a person says, okay, I'm ready. If you're gonna say we're gonna take 8 days for a pre-authorization, chances are they're back using and they're not gonna come back. So you have limited opportunities.
Or they're gonna die.
Or they're gonna die. And I work with our medical director, has private practice, and she had a pregnant woman who was addicted to opioids, and when she became pregnant, she immediately wanted to get off the opioids. She was on Medicaid, doctor wanted to prescribe buprenorphine, 14-day. And in that time, because the woman was like, I'm not gonna, inject or do anything else while I have the baby, because she went into withdrawals, she had a spontaneous abortion and lost her child. Because that's what happens when pregnant women try to withdraw, they will lose the baby. Well, there's a great chance, not necessarily, but there's a big chance. So these are some of the things that are really happening out there. So these are my ideas.
Quick question
yes.
for you. Is there anything that you're looking at as far as telehealth? Because we have 2 opioid abuse navigators that are busiest EDs that are doing some great work, but some of the barriers, of course, is getting into treatment, but just getting through the biopsychosocial assessment. That if that could be removed, just to get that person into treatment and then go through the assessment, because when someone's ready for help, they're ready for help, and saying, come next Tuesday at 8 o'clock for your assessment, doesn't work.
It doesn't, and that's where we really need to look at, and that we need to, as a state, again, I always start with what can I change, because I can't control everybody else, but I can control what do we need to do in our rules to make it easier for people. And I think everybody needs to look at it that way, our providers, our, other funders, whether it's Medicaid, what can we do to solve this problem? But you're absolutely right, and the medication first model is, if the only thing you need to know is that that person is addicted to an opioid and could benefit from MAT, give the medication. That's it. And then don't let lengthy assessments or intake sessions get in the way. Do that first, and then, and it really makes more sense, right? Because opioids really cloud your brain. They really kind of, they hijack your brain. That's what they do. So I always kind of think, is this really the best time to initiate therapies when you're not thinking clearly, when you're not making good decisions? Let the medication clear you up a little bit, and then you can talk about those psychosocial, behavioral health supports. And again, this doesn't all have to be residential treatment. In-home services, one of the biggest barriers is transportation. Who can sit in residential for 3 months, 4 months? You're gonna lose your job, right? So whatever we can do to provide services in the home, via telehealth, in ways that people can do it out, and keep their jobs. And I think there's a perception. People always ask for residential because that's what they think substance use treatment is. But like, for example, in Jacksonville, the Hospital Bridge program there, which has had great success, they gave people choices and said, you don't have to go to residential. And when they gave people choices, most of them said, no, I'll just go to MAT and I'll see a therapist when I can, but I want to stay with my family and keep my job. And residential was not their choice. So, and I'm not downing any type of service. I think our job is to offer as many options as possible, and then really talk to people and see what can they do, what are they willing to do, and start where they are. So it's individualized care. I'm done.
Ute, take 60 seconds and go to your policies real quick and talk about what you would change there. You had one more slide. That direction. Here you go. There.
Okay, so again, policies focused on services for addicted people improve population health. And what they were talking about, again, this is from the Public Health Journal, these are the type of things like medication-assisted treatment, needle exchanges. Almost all the research has shown that these are not harmful in any way. Because honestly, nobody starts using heroin because they know they're going to get a clean needle. That's not an impetus. You'll also hear people who are not fans of naloxone say things like, oh, now people are having naloxone parties. There's no such thing, guys.
That's fake news.
There's no such thing.
It's literally
There's
fake
no
news.
heroin addict that says, I'm going to shoot up as much as I can, take naloxone, go into instant withdrawal, feel horrible, and have just wasted all the drugs that I put into my vein. There's no such thing. It's myth.
Research it for yourself. I did it.
Yeah.
And the provider said, oh no, I heard in so-and-so, and I looked it up and looked it up and looked it up. It was completely made up.
There's no such thing. Nobody wants to do that. So reducing the prescription opioid supply, which is one of the things, one of the bills that passed last year, we need to be ready that as we're seeing big decreases in those prescriptions, that we're going to see some of the trends we saw when we closed the pill mills.
Which, by the way, should be the biggest fear for communities around America. You saw that graph go down and then it go back up. 19% of the opioid prescriptions in America were cut off last year. What are, for those that do this treatment, Dr. Ute, if someone's addicted to opioids or they've moved to heroin, what are the odds of them just cold turkey? 0%?
It's
2%?
It's less than 10, less than 5%.
Meaning just on their own, no treatment, no it's very few people have the ability to just shake off opioid addiction statistically. And so the number I've heard in the state of Florida of people with opioid abuse disorder is in the hundreds of thousands.
Well, yeah, because we have 22 million people, so even if it's just
so those people now are no longer going to get oxy legally. What happens then?
We're going to find it somewhere.
There's going to be a need for the greatest amount of resources we've ever seen in our state and our country's history over the next probably 3 to
And
5 years.
Again, it depends, were those people addicted or not? I mean,
Yeah.
if you're not, if you're not taking opioids at a level, you're not gonna go through withdrawal when they're, like, I mean, you and I can have surgery, we'll get opioids, we'll go off of them, nothing will happen. But for those that do have a physical dependency, yeah, they will have withdrawal and they will find something else.
Give Ute a round of applause.
Thanks.
One question for Ute.
All right, question.
So buprenorphine and how it's utilized in the state and how we can encourage hospitals, physicians to get the X waiver or get Florida to figure out how to way to remove that X waiver requirement. So between Dr. Wall and you, kind of give a little bit of brief overview on how that works.
So basically, for any physician, and it used to be just a doctor, now ARPs, physician's assistants have been approved. They have to go through an 8-hour course through the Substance Abuse and Mental Health Services Administration. SAMHSA, that's the federal entity that is over substance use disorder treatment. It's free, but it does take 8 hours of time from a physician. And it's called the Data 2000 waiver. It's mostly, I mean, to be perfectly honest, it's really not a SAMHSA thing, it's a DEA thing.
Do you have to take
Drug
an 8-hour
enforcement.
class to give out Oxy?
No.
Oh, it's interesting.
Yeah.
So, Ute, have a seat, love you. So, just thought about that.
Yeah.
By the way,
You can prescribe that all day.
I don't want to get into that outrage. I like this outrage point that they've made, but I'm not going to go down that road. Let me bring Spence up. Just the fact that I have a slide. Spence Pfleiderer, he's going to close us out. We're going to go till 10:05, and if you have to scoot out after 10:05, we're going to close and everyone can hang out and have food. But I will tell you this. There would be no Project Opioid without Spence Pfleiderer, without Florida Blue. Keep Tony Jenkins in your prayer. Did the Florida Blue rep leave? Yeah, I don't know if you know this, but Tony had a stroke probably 3 months ago. And he is, they pulled a piece of blockage out of his brain the size of my pinky. And so he's working and he's okay, but he's struggling, or he'd be here today. He sends his regards. But Project Opioid started really at the inspiration of Tony and Spence. And as a question, we were at an event that Spence was doing. He runs Central Care Mission, where they have upwards of 60+ men at a time in recovery, overcoming all kinds of addiction, including opioids. But listening to the mothers of those that have lost their sons, and listening to Representative Duran's story, we said, hey, as a community, we've got to do better than this. There's got to be more available. I will tell you, as Spence comes up and talks, he's going to talk about the need for behavioral health services and the need for addiction recovery options. I'm a novice to this. I've been working on this issue now, just in my time with them. I'm learning. But I will tell you, as an outsider, it's interesting to see this debate. It's not just here, but everywhere, on the opioid crisis and on addiction in general. And the debate is, do we give people medically assisted treatment when they're addicted? Or do we give them behavioral health? And you see this debate every day in your life, in your world. And I would tell you, in my opinion, it's both. We need absolute harm reduction through medically assisted treatment in a way that's different than alcohol and other substances, because if you overdose tonight on alcohol, you're not necessarily in danger the way you are with fentanyl. But at the same time, addiction recovery is an important part of harm reduction and in transformation for so many. So we want Spence to close us out, talking a little bit about the need statewide and locally for more addiction recovery programs. Give Spence a round of applause. Thank you.
Well, good morning, everybody. Man, I love what you said. I've been doing this for 10 years, dealing with methamphetamines, alcohol, benzos, heroin, fentanyl, almost any substance that can wreck a person's life. The men that I deal with are the men that we care for. I've done their funerals. I've been to the hospital and watched the plugs pulled and watched people that I love and cared for a year, die. So I know the pain. My stepson, my son-in-law, 14 years in addict, now 1 year clean. 1 year. Back with my granddaughters. Back with my daughter. Going to work. Buying their food. So I understand it's both as a service provider and as a family member. As Andre said, it's not an either or conversation. It's a both and conversation. I'm here to talk to you about some of the behavioral health components. Let's talk about causes first, because I think if we can get a grip on some of the deeper underlying social causes, then we can understand why, when a society begins to take opioids, that they absolutely latch onto it and become addicted. 3 books, very, very important books. 1, Hillbilly Elegy by J.B. Vance, where he discusses the causes of that. 2nd book is Lost Connections by Johann Hari, where he talks about and does great, great research on what is going on in our nation and across the world with anxiety and depression and why we turn to opioids to solve some of those problems. Yes, we'll get into those. Third book, and when you said that, I just forgot what that 3rd book is, but I'll come back.
My fault, sorry.
No, that's all right. Dang it. But anyhow.
There's a book called The United States of Opioids.
Oh, come on, Andre, I'm talking now. So, my point is, I'm compiled reading, and here they are. And this is so key. Trauma. Doesn't matter what it is, trauma. Sexual abuse, verbal abuse, physical abuse, abandonment by parents, isolation, economic desperation, poverty, depression, anxiety, and kind of the list goes on. Now here's the key to this. This is the key to understanding why our society en masse is moving that way. We take an opioid for physical pain. That's what the prescriptions were for. Emotional pain happens at the exact same place in your brain as physical pain. It interprets it and it functions in the same exact place. So if I'm not in physical pain, but I'm in really deep emotional pain, whether it is from years ago or currently, I take this opioid. Some people aren't in pain, but if I am, all of a sudden it makes me feel good. And I say, I gotta have me another one of those. Just one. And maybe a drink. And a month later, I'm taking 5, and I'm taking 2 drinks, and I'm on the road, and I'm on the path to destruction. Those are the underlying causes. So let me talk about 3 components that, I'm not here to talk about Central Care Mission, but I need to talk about it because it's what I do, and you'll see some examples to it. So the first component is, I'm the one pushing the button, are what we call pillars of success. And you guys have talked, we've talked about this. So our first pillar of success is clean and sober. If all we do in 30 and 60 and 90 days is get someone clean and sober and we don't help them address all the other issues of their life, the probability of them staying clean and sober, whatever that means, is radically reduced. So what we cannot in mental health is focus only on clean and sober. It's obvious we must focus on that. But then the second thing is stable employment. Let me say this. You might have all these components, these causes by your history, but if you all of a sudden find yourself addicted to prescription drugs and you're now on the street shooting heroin and overdosing, you have these problems of employment, housing, transportation, family issues, and broken relationships. You now have them. You might not have had them in the beginning of your life, but when you start to become an addict, you have all of those. And so this is what we want to do, put them back together. Stable employment. We have nearly 100% employment on any given day. Sometimes we had 80% because we get a lot of new clients and they have to stabilize. They go to work, and here's the issue that you brought up. We have 5 vans where we transport them to work. We don't put them on a public bus where they drive right by where their dealers were, right by where their friends were, And they can say, hey, stop that bus, I'm getting off. And now let me go shoot some heroin, and they're dead that afternoon. We take them to and from work. And then we help them. They keep that job when they leave. We're a one-year program. Stable employment, stable transportation, stable housing. They can stay there for a year. And they'll gripe and they'll complain and they'll say this place sucks and you're an asshole and all that kind of stuff. They'll say all that. And then when it starts to be 9 months and they're looking at the end of their 1 year, they come to me, doctor, and they say, can I stay a little bit longer because I think there's some deeper work that I need to address. We said, absolutely, you can stay here as long as you need to get yourself stabilized. Relationships, stable relationships. There is a weight of destruction behind an addict in all their primary relationships. They destroy the people around them. They destroy their homes, their nuclear family, the peace that they have, what they're trying to create. And to take this step back into that family is a critical element. And here's what we ask them to do first. We ask them to simply write a letter asking for forgiveness. Will you forgive me? And you know what? They don't. Not yet. And it just takes time. And then community involvement. I run Central Care Mission. I'm also the director of Compassion Corner. We care for 10,000 homeless a year coming off the streets. We help them get bus passes. So on Sunday morning, every Sunday morning, 6:30, we have about 200 homeless people come in and we feed them. And after they listen to me talk about their life can be different, they'll come up and say, can I talk to you? I say, sure. See me Monday morning at Compassion Corner. And they'll come into our program. The next month, or the next week, I'm going a little bit longer, okay, because everybody else went longer. The next week, if you were homeless and you talked to me Sunday and I brought you into my program, the next week, if you're homeless, you're now feeding him the next week. And he says, hey, Sam, you're off the street. And he says, yeah, John, don't you want to get off the street too? So they go back to the very people that they were once with using, and now they're serving and feeding, and they're saying there's hope. I'm getting off these substances. Second component, our life skills. We are faith-based, and you're going to see in a minute, science-driven. And you don't see those two components put together hardly ever. You see them argue and point fingers and diminish and demean. No. There's no solutions in that. It's faith-based and science-driven. So by faith-based, here's what we say, and you talked about, Doctor, the dirty issue. We never use that word dirty, ever. Here's the faith-based component. God loves you. He made you. He absolutely delights in you. And He is here to jump in the pool with you and swim for your life. Let's talk about regret. Let's talk about forgiving yourself. Let's talk about, there is shame. People do desperate and morally wrong things while they're on these drugs. It's not the drug that is immoral or the use. It's those other components of, I stole all my family's, I stole my grandma's wedding ring that goes all the way back to, Germany in World War II. There's where those issues are. Next, physical. You have to address the physical condition of the body. So we have 20 mountain bikes, weightlifting set, volleyball, full court basketball, and 3 times a week, we get our cardiovascular rate up above 65%. What does that do to your brain? It floods your brain with endorphins, endogenous morphine. If I'm wanting morphine, if I'm wanting heroin, and then I go do this, and then I constantly reinforce positive endorphins, it helps me overcome addiction to opiates. The emotional component. The emotional component has to do with depression. It has to do with anxiety. It has to do with anger. Now watch this. It's so easy to talk about the negatives. You said it. Using opioids completely deadens your soul.
the thing that rises up first are the negatives. But what we do teach and do help them do is once again feel love. Experience joy. And move into peace. The positive emotions. Our financial. Everybody wants to go to work. We're a working program. They pay for being there. We uninsured. We take all uninsured. You walk in with a Target bag. That's about all anybody walks into. They are devastated. They have nobody. And they have nowhere. And we help them get a job. Average savings of our guys in the program is about $3,250. That's average. They are leaving, and I'm going to address this real quick. Yep. They are leaving with nearly $10,000. Now, that should raise a red flag. Aren't these opioid addicts? Aren't they alcoholics? Aren't they addicted? You're going to give them $10,000? No. Here's how we're going to do it. My wife, she runs. I act like I run it, she runs it. 3 months before they leave the program, of that $10,000, they get to start their own bank account. And they get $500. And at the end of the month, we look at that, $500. You spent $500? We feed you. We take you to work. What do you do? And we look at it, we look at their bank account. They have to show us their bank account. 7-Eleven, Twinkies, coffee. And you can blow, you guys know, you can blow $500 at 7-Eleven if you're there 3 times a day, 30 days, it's gone. And they say, I can't believe it. I don't have any money left. So the reason we give them $500 and not $5,000 is we want them to learn that you can spend $5,000 just as easy as you can spend $500. We do that for 3 months in a row, and they have to have a clean slate of spending to where they learn to self-control and self-moderate their spending before they can move out of the program. And we know they're not going to take that $5,000 or $10,000 and then throw one of those parties we just talked about. When someone relapses in our program, and I want to address this, we do not kick them out. There's one reason we do kick them out. If you bring a needle in and a bunch of heroin and everybody's shooting up, it's one thing to maybe commit suicide, it's another thing to commit suicide and murder. And so we say, hey, we have people relapse in our program, and we love them, we care for them, we deal with the failure, just how bad they feel, and they can't believe it, and I thought I had that. I thought I was clean, I thought this was good. And we sat down and say, yes, now let's do the deeper digging work to find out why this happened again.
Spence, pause 1 second.
Yeah.
Representative Duran has to leave. He's his flight in 45 minutes. Everyone say thank you to him.
Thank you
All right, keep going, bud.
He's leaving, and I was going to tell him I got a great program that he can support.
He has my contact information, has my cell phone, my email. By all means, happy
We'll
to continue.
supply that to everyone here. Thank you, buddy.
Thank you.
Safe flight.
All right, I want to get to the science of this, and then I'll be done real quickly. Addiction is a brain issue. That's why today I can be a perfectly normal human being, and a year later I can be a person with substance abuse disorder. Because I have taken opioids, and those opioids have created neural pathways in my brain that are dopamine supported. And the more you use, the wider the river gets. And the more dopamine it takes, and the more drugs it takes to make that high hit. That's why we don't understand when someone says there's fentanyl out on the street, a drug addict will say, I'm going to find the fentanyl. Because they're after the dream high, they're after that original high. So, part of our program is to take the brain and to rewire that brain through habits, skills, and activities so that now the dopamine is not going down the neural pathway of opioid addiction, it's going down other directions. Let me talk about those areas real quick. Exercise, we know that. Exercise, exercise, exercise. 3 times a week, we exercise. We go out to the mountains. If there's mountains in Florida, there are, called Mount Bird. And we climb hills on mountain bikes. Okay? Next, meditation, contemplation. All the science says that meditation directly affects 6 areas of your brain. And the habit of it takes the dopamine and moves it from one area and begins to create a habit in another area. These are habit transferences, learning new information. Now, this is like tactile things almost, chess, or playing a new card game, or learning how to fish. This is not new intellectual information. I'm going to get to that. These are things that you actually engage and have to intentionally. By the way, when you put a needle in your arm, it's intentional. These are things that you intentionally do. Linear logical reading. Adriana Wolf from University of Berkeley, California, put out 2 books about this. Not text reading, not blog reading, not social media. None of that reading creates different pathways. Linear, long-term, nonfiction reading where someone learns paragraph to paragraph, sentence to sentence, chapter to chapter information. At our facility, these guys come out of prison. They've been using 5, 10, 15, 20, 30 years. They've never read a book in their life. And they will read 12 books in 1 year about these things that we're talking about. Next. Then, they get really mad. Let me say, you got to write a book report. That's 3 pages long about what you just read. Because you have to process it. Healthy social interaction. Oh, people get mad. And we let them get mad. People get angry, let them get angry. Then you sit down and have the real conversation. And repeated exposure to nature. They took, this is a recent study that came out, they took addicts and put them in nature. They took addicts and put them in nature. Then they took the double-blind who were addicts, and they didn't put them in nature. They set them down, and they gave them a pencil and crayons and said, draw a picture, self-portrait of yourself. People who were out in nature, the picture that they drew of their own face was half the size on the sheet of paper as the people who weren't. Becoming unaddicted is becoming unglued from your own ego. And that's what happened. So we need funding, mental health funding across this state that takes medically assisted treatment. Then what? Then we do recover. We do well. We care for the whole person. That's what we do. Thanks,
Spence. Last 60 seconds, let me just say thank you to our guests, Representative Duran, Ute, Spence. We want to, again, think about from a statewide perspective, how are we going to create an agenda for resources, for programs, implementation, policy changes that are going to get people harm reduction, save lives, and ultimately help people recover and stay safe and live better lives. That's what Project Opioid is doing. We're going to be recruiting some of you to be a part of, Ute doesn't know it, but she's going to be one of our executive leaders on our data and strategy committee, along with Aaron Wall and a few others. And we have an opportunity. The last thing I'll tell you is this. We have an opportunity to, in this community, timing. One of the people I used to love when I was younger used to say, the opportunity of a lifetime must be seized. The pastors on this side are nodding their head. It's a spiritual quote. The opportunity of a lifetime must be seized in the lifetime of the opportunity. The opportunity of a lifetime must be seized in the lifetime of the opportunity. We have an opportunity over the next 6 months, I believe, that is divine in nature, with a governor who I believe is committed to this issue, great business and faith leaders, and a moment where we can save a lot of lives and transform our community. So thank you to everyone. Give a round of applause. Hang out. We got food.